So hello and welcome back, guys. In this section we'll be dealing with the part 2 of the medicine recall NEET-PG 2022 questions. Obviously you all know that the recall questions, as far as possible, we try to get the opinion of the students. These questions may not be accurate sometimes as to the exact figures, but definitely they are a very important players in not only understanding the pattern of the questions, the exam way in which the exam has been set, and the way in which the questions have been asked. As far as this NEET-PG is concerned, I can say one thing for sure, guys, that this was a very easy paper. Whatever the questions were there, they were from the typical bracket of questions that generally get asked, and very few percent of the questions, you can say, were really tough. But rest everything was very clear cut, easy. Whether it is image based questions, the radiology questions, the sometimes the students say that maybe this subject was asked more and this subject was asked less. Like this time students felt that maybe the OBGY section and the microbiology section was given too much of a weightage. But we need to understand, guys, sometimes what we feel is that the question is probably from the obstetrics and gynecology, but actually the question may be from either anatomy or maybe from either the medicine side. Like in one of the questions, the obstetric pelvis, and which areas this was asked. This can be a question from anatomy, as well as this can be a question that can be dealt with OBGY, right? So we have certain questions, like one of the question was bicornucate uterus that came. So it was a radiological image that was there. So one need to understand that it can be a radiology question, or also it can be a OBGYN question. Same goes with medicine as well. Many times we feel that the drug of choice, sometimes certain things may be from the patho side, but or pediatric side. So what we have tried to do is we have tried to sum it up as much as possible to the core medicine discussion, and we'll be dealing with the questions. So let us start without any delay with the first question. So the first question that we deal with is dealing with pulmonary edema. This is a question that is based on hypertensive emergency, and what is being asked that the patient is having uncontrolled hypertension. Patient has uncontrolled hypertension and he develops an acute onset of breathlessness. Some value of blood pressure was given. Obviously we cannot be sure as to what the value of this may have been given. Then the radiological image definitely was provided, and this was a hint actually to come to the diagnosis. The hint was, it was you can say a typical perihilar shadows that were shown, and this is a typical arrangement, or what you call as a perihilar diffuse haziness. Perihilar diffuse haziness, this is called as butterfly appearance. Butterfly appearance of the pulmonary edema. This can be a differential diagnosis, guys, in some of the important DDs that can come along with this as far as this radiological image is concerned. So this can come as a differential diagnosis for miliary tuberculosis. This is an important differential diagnosis for ARDS, and obviously the pulmonary edema part, where you have or a congestive cardiac failure, the question can be aligned with it. But here we are dealing with a hypertensive emergency. And we have different options. Here I have put up 5 options instead of 4, because there was a discrepancy among one of the option as to whether the option was O2 support with ventilation or O2 support with IV antibiotics. So O2 support with antibiotics or O2 support with ventilation. Now the treatment option or the answer will vary tremendously if these options get changed. So we can see here that what are the precipitating causes of the cardiogenic pulmonary edema. It is given over here. Here you can see in this diagram that we have acute any sort of arrhythmia, whether it is a tachy or a bradyarrhythmia, both are given. Infections, fever, acute myocardial infarction, but the question in our discussion is the acute severe hypertension. So it's the acute severe hypertension that is precipitating the whole story. How do you manage this pulmonary edema? So this is the management protocol that is given in Harrison, guys, and you can see there are two important zones in which we manage at this critical. This is a critical care medicine topic, how you manage this patient. Obviously the things go simultaneously, but the important thing is, number one, you go for the supplemental oxygen to achieve the oxygen saturation, and along with it you go with a positive pressure ventilation. The funda is very simple. The funda that we need to understand, guys, that this is the alveolus and this is the capillary bed. Due to some cause, cardiogenic pulmonary edema, whatever, the water has come into this zone. This space is filled now with fluid. It is flooding with fluid, or maybe it can also go into the alveoli. Now we know that O2 and CO2, they have a different mechanism of diffusion. One is diffusion limited and the other one is the pressure limited. So what we can see is that if we want to increase the saturation of O2 over here, what we need to do is we need not only to give oxygen to the patient, but this oxygen needs to be pushed down. It needs to be pushed to cross this barrier, and here is where the role of the positive pressure ventilation comes into play. So this is a very, very important line of management that needs to be dealt with. The primary problem because of pulmonary edema is not the hypertension, but it is the alveoli that are flooding with the fluid. So you take care of that by giving supplemental oxygen and giving a positive pressure ventilation. Second important management strategy is to decrease the preload. Now we want to decrease the preload, and in this we have certain drugs getting mentioned over here. The first and foremost that the Harrison mentions is loop diuretics that you have to give intravenously. So you give intravenous furosemide initially, lower dose, and the second drug is a nitroglycerin. So here in the options, if we can see what will be the answer to the question. If in the wording, what should be initiated, what strategy or what treatment should we begin with, and if the option number 4, that is O2 with ventilation, is there, then I think this is the best option. This is the best option. Preload reduction by giving nitroglycerin definitely is an important strategy, but if the question was asking which was the drug of choice, if the question was asking which is the most important drug treatment that you initiate, then definitely you come to IV nitroglycerin. Then if in the option it was antibiotics with O2 support, definitely the answer will be nitroglycerin. So this is an important topic of the NEET-PG discussion, where we talk about the hypertensive emergencies, and in hypertensive emergencies there are some allied topics as well, like what are the important drugs that we'll avoid in patients of hypertensive emergency. So we avoid beta blockers, we avoid hydralazine, we avoid diazoxide, minoxidil, and finally we also avoid the nitroprusside. We avoid the nitroprusside, and we can see there are two important drugs that are an important drug of choice for hypertensive emergencies. Drug of choice for hypertensive emergencies. Hypertensive emergencies. So two drugs are mentioned. One is nitroglycerin and the second one is sodium nitroprusside. But here important thing to note is that in hypertensive pulmonary edema, this drug is contraindicated. So that is what is about this question. The next question was fairly very simple. It was based on a pulse that was irregular. The patient has palpitation, and along with that blood pressure value was given. One important hint that was given was the patient is having a apex pulse deficit of 20. Obviously these are very simple indicators, and the patient in question is having atrial fibrillation. Atrial fibrillation. So here are some of the things from our notes, guys. So let us see. So atrial fibrillation was there, and what was asked is the apex pulse deficit, what will be present in the patient. Obviously the answer is there will be absent A waves on the JVP. This is a important finding that you see in a patient of atrial fibrillation. But some of the important things regarding this, guys, whenever we talk about the patients of atrial fibrillation, there is a heart rate that is generally given. We have to be very careful, students have to be very careful as to what the heart rate is. Generally whenever we talk about the atrial fibrillation, we know that the heart rate is something between 350 to 600 beats per minute. But remember and look into it carefully that it is the atrial rate that is between 350 to 600. Ventricular rate due to the blockade provided by the AV node, the incremental blockade that is provided by the AV node, comes out somewhere around 120 to 160 beat per minute. Ventricular rate is low, but this ventricular rate still very high enough. 120 to 160 beat per minute is still very high to cause problems with the cardiac output and the cardiac filling. Then obviously you have the P waves, you have the fibrillary waves or S waves that are there, the apex pulse deficit that is greater than 10. So it was a fairly very simple question that was asked. Patient presents with Decoxian toxicity. So this again is a question, guys. This type of question, generally whenever a drug is excluded or becomes a tertiary drug in the management of any disease, generally those drugs are less frequently asked. So Decoxian in the management of cardiac failure has now become, due to the availability of better drugs, has become you can say the tertiary choice of drug. But still a question has been asked, but we can see there is a link between why and how these questions have been framed and asked. So Decoxian toxicity is there to the patient, and the patient has bradycardia. On ECG the patient is showing a third degree heart block. What should be the best treatment available? Options are Decoxian antibodies, then lidocaine, DC shock, and phenytoin. What we can see, guys, in this, all of these three options, lidocaine, DC shock, and phenytoin, they are all used for tachyarrhythmias. They are all used for tachyarrhythmias, but here the question specifically mentions that the patient has a brady kind of a arrhythmia. So when the patient has brady kind of an arrhythmia, obviously the drug that we'll be using will be a Decoxian immune Fab antibody. But we'll again come to the answer. But there are some important points that needs to be discussed with this question. Number one, there's a very important investigation that is to be done in patients of Decoxian toxicity. What is that? It is serum potassium levels. Why we look for serum potassium, we'll see. It's a very important discussion. So Decoxian toxicity can be an acute toxicity or it can be a chronic toxicity. So if it's an acute toxicity, there is hyperkalemia. Potassium levels are increased. If it's a chronic toxicity, there is low potassium levels. There is low potassium levels. Why this potassium is important? Because potassium is competing. Potassium is competing with decoxin. Potassium is competing with decoxin for the binding site of this important challenge, sodium potassium ATPase. Sodium potassium ATPase. We know the mechanism of action of decoxin. So these two compete with one another for the binding site, and that is why one of the important predisposing factor that we have for decoxian toxicity is hypokalemia. Hypokalemia predisposes the patients for the decoxin toxicity. Then coming to the next important thing that needs to be taken care of, if you have decoxin toxicity, you don't give calcium to the patients. And lastly, one more electrolyte abnormality that needs to be corrected or taken care of is magnesium, hypomagnesemia. Obviously, there are indications for the Fab antibody. If we want to give Fab antibody, what are the indications? Number one, the patient having arrhythmia should be a hemodynamically significant arrhythmia. Hemodynamically significant arrhythmia should be there, or the patient should be having a Mobius type 2, second degree heart block, or a third degree heart block. And lastly, the third important criteria for giving immune antibodies is serum potassium. You look for the serum potassium, and if the serum potassium, obviously in acute poisoning, if it is greater than 5 milliequivalents per liter, then you go for the Fab antibodies. In case of acute poisoning. So our question, clearly the criteria given is third degree heart block along with bradyarrhythmia. So the answer, the best answer is the Fab antibodies or the decoxin antibodies. Now coming to the again one more question. In this NEET-PG we can see, guys, that the questions have been framed right from decoxin, then this will be one more question, and there is again one more question on potassium and the ECG levels in the potassium. So one needs to understand that there are always a series of question on a certain topic that gets set. So decoxin is primarily having role of potassium, then which is the drug used to decrease the extracellular potassium. It's a common question that generally comes, whether it's lactic acid, glucagon, epinephrine, or atropine. To answer this question, first we need to understand the management of hyperkalemia. Management of hyperkalemia happens in 3 stages. The first one is to antagonize. First priority will be to antagonize the effects of potassium on the heart. That is the antagonism of the cardiac effects. For that we give IV calcium gluconate, which stabilize the membrane. The second is rapid reduction of the potassium, and this is what was asked. How do you rapidly decrease the potassium level? So for rapid decrease of the potassium level, the first or the best choice, if it would have been given, would have been IV regular insulin. IV regular insulin, and you add it along with the 50% dextrose, that is D50. Second option that is there is beta 2 agonist. And in the beta 2 agonist, most commonly given is albuterol. Most commonly given is the albuterol. Thirdly and the last, part is the removal of the potassium, that is done by with certain resins like sodium polystyrene sulfate. Then you have the diuretics, or you can go directly with the dialysis if the patient is unable to be managed. So definitely we didn't have the regular insulin as an option. What we had instead of albuterol, what we had was epinephrine. Obviously the lactic acid, glucagon and atropine are all out of question depending upon the extracellular potassium that is to be rapidly decreased option is there. So what is that thing that causes increased entry of potassium into the cells? Okay, obviously what it is telling with lactic acid is when you give acidosis or when you cause acidosis, that is a hydrogen and a potassium exchange that takes place, but that does not apply over here. Next, coming to the next question, a patient is posted for a surgery and is complaining of fatigue. So this is an additional hint that is given, and ECG shows ST depression and a U wave. So what you have was ST depression and you had a U wave. Obviously ST depression can be anything. If a patient is posted to a surgery, it can be angina, it can be anything, but the patient has complained of fatigue. That means the examiner is giving a very specific hint, and the hint is for the hypokalemia. So here in ECG we can see the hypokalemia patient, they present with, you can say that it's a kind of a push phenomena. It's kind of a push phenomena. Somebody is pushing from the up. Somebody is pushing from the up, and this is hypokalemia. This is hypokalemia, in which what you have is a ST depression. There is a ST depression. There is a QT prolongation, and finally you also have a flat T wave. You have a flat T wave. The similar funda goes with the ECG of hyperkalemia, and so in hyperkalemia what we see is, in hyperkalemia what we see is an ECG which is showing tall tented T waves. Showing tall tented T waves. That means something has pulled it up. Something is just pulling this ECG up. So this is tall tented T waves. Just like a tent. Tall tented T waves. So the question was fairly simple, ECG of a hypokalemia. Next question that is there, again it's a arrhythmia question. There is a 74-year-old male presenting with a coronary artery disease and with palpitation. ECG is as shown below. So the ECG strip was shown, and clearly you can see that this is a ECG of ventricular tachycardia. We know that ventricular tachycardias are monomorphic, or maybe they are the polymorphic ventricular tachycardias, that is what we call as torsades. But this is not a polymorphic. Single ECG pattern is there. Broad QRS complexes were there. Broad and blunt QRS complexes were there, and you had a blood pressure of 120 by 84. Fairly stable blood pressure is there. What should be the best treatment? So whether it was an option between two drugs, metoprolol and amiodarone, oral or IV. So the best option is IV amiodarone. Whenever the questions are asked on ECG, guys, these questions fairly are very simple if you take into consideration this chart and you go along with this. Number one that they will ask you is, they will give you a ECG strip and they will ask you to identify that rhythm. Just identification. So you should have seen that ECG, whether it's a delta wave of the what we call whether it is the delta wave in the QRS complex, of the WPW syndrome, or you can say whether it's a hyperkalemia, it's a hypokalemia, it's a bradyarrhythmia, with a tachyarrhythmia, with a ventricular tachycardia, with a supraventricular tachycardia, first degree heart block, Mobis type 1, type 2, or whether it is a complete heart block. All of these are ECG strips that may be given. If you have seen it properly, we'll be able to answer these questions clearly. Second important thing, to go and identify a rhythm, sometimes we need to identify how the QRS complexes are. QRS complexes are the most important phenomena. From where is this ventricular beat originating? It's a very, very important thing. We need to understand whether the origin is from atria or whether it is in the ventricle. So we need to look for the ECG complex and see whether it's a narrow or it's a broad. Narrow is less than 0.12 and broad is greater than 0.12. So if it's a narrow ECG complex, that means it's a supraventricular tachycardia. It's a broad, that means it's a ventricular tachycardia. You can see over here that the ECGs are fairly very broad and blunt. So definitely it tells you that this is a ventricular tachycardia. Now coming to the management, you have to look for the symptoms, and in the symptoms part they ask you question on a very important zone, whether the patient is a stable patient that is requiring the management or whether the patient is an unstable patient. So stable and unstable. So what's an unstable patient? An unstable patient is a patient who may be having a low blood pressure, patient is in shock, patient is having a coronary artery disease or acute chest pain, or the patient has altered mental status. Patient has altered mental status. All of these come under the category of an unstable patient, and for an unstable patient the answer is clearly DC cardioversion. You shock the patient. If the patient is stable, that means no other thing is mentioned. Here you can see we had a fairly stable blood pressure that was given in the option. So this is a stable patient that is there. For a stable patient, if it's a supraventricular tachycardia, the drug of choice is adenosine. If it's a ventricular tachycardia, the drug of choice is amiodarone. It's a amiodarone. Obviously you give these drugs IV. Next, coming to the patient has dental caries and has come for dental extraction. In which of the following we don't give? We don't need a prophylaxis for endocarditis. So here is a table from Harrison, guys. So if the patient is having a prosthetic valve, we go for it. Prior endocarditis, we go for it. Cyanotic congenital heart diseases, we go for it. So here in the option you can see that patient is having previous carditis, you go for it. You have the previous prosthetic heart valve, you go for it. Cyanotic heart disease, you go for it. One of the options that you don't give prophylaxis is ASD. You don't give prophylaxis for the ASD. So ASD is the answer over. So to end our discussion, we have this final question. Patient is having acute onset of stroke and this patient is developing flailing ballistic movements. What do you do and what is the site of the lesion? So what do you do with this question? Again, a very simple question, but some of the students had some difficulty with this question because they said that in this Huntington's disease, what we have is chorea. Chorea is in Harrison. If you look up, you will see that in chorea also it is given the patient has some ballistic movements, but these are not flailing movements. In chorea they are different kind. Ballism are flailing, ballistic, like a ballet dance movement are there. So you can see in the option for the chorea we have the lesions at striatum and also at the caudate nucleus. But if we had to pick one of the option out of the two, the most striking changes most striking changes, they occur in the striatum area. So here obviously this is not a case of chorea or Huntington's disease. This is a clear-cut case of hemibalism. The answer is subthalamic nucleus. So obviously caudate is out, putamen is out, and striatum is out. The answer is the subthalamic nucleus. So that is what is about the part 1 of our questions, recall questions on medicine. So that is all about our part 2 of the medicine recall questions in NEET PG 2022. We'll come up with some more questions of NEET PG 22 and discuss. Follow us on Instagram at MedCompanion, and also follow our YouTube channel at the MedCompanion. So hope to see you soon with the next videos. Till then, thank you very much.